Hello everyone. So let us study today about pelvis. Right? See, the pelvis, when they ask you to hold, you have to hold at an inclination because the pelvis, it makes an angle to the horizontal about 55 degree. Okay. So pelvis is made up of three bones. One is innominate bone, then sacrum, and then comes the coccyx. Innominate bone is made up of ilium, then comes ischium, then comes the pubis. Okay, so how many joints are there? There are three joints. One is pubic symphysis, symphysial joint, then you have sacroiliac joint, and then you have sacrococcygeal joint. So pelvis is a system which connects axial skeletal system with appendicular skeletal system. Axial skeletal system is our spinal cord. Then appendicular skeletal system is our the femur. Okay, so it connects the axial to appendicular skeletal system, right? Then comes pelvis is divided into two types. One is true pelvis, another is false pelvis. True pelvis is below the level of pelvic brim. False pelvis is above the level of pelvic brim. And based on shape, pelvis is classified into four types, that is gynecoid, anthropoid, android, and platypuloid, that is Caldwell-Molloy classification. Okay, so now coming to pelvis per se. We have pelvic inlet, then comes pelvic cavity, and then is the pelvic outlet. Okay, coming to the pelvic inlet, here inlet anteroposterior, each inlet cavity outlet has AP, transverse and oblique diameter. Okay, so the AP diameter in inlet, it is divided into three types. One is anatomical anteroposterior diameter or true conjugate or conjugate vera. Then you have obstetrical AP diameter. Then you have diagonal AP diameter. How to remember? Diagonal is the one which you can diagnose to clinical vaginal examination. So diagonal conjugate is from the lower border of pubic symphysis to that of the sacral promontory. That is diagonal conjugate which you can measure. But it has no obstetric significance. What we want is obstetrical conjugate. So what you get from the diagonal conjugate, if we minus 1.5 to 1.5 centimeter, we will get obstetric conjugate, which is from the prominent point in the pubic symphysis to that of the sacral promontory. Whereas anatomical conjugate is from upper border of pubic symphysis to that of the sacral promontory. Okay, so this is about AP diameter. Remember, in inlet, transverse diameter is more compared to that of the AP diameter. So the AP diameter, how you can remember easily is, put a table, inlet, cavity, outlet, AP, oblique and transverse diameter. Okay, or transverse oblique AP diameter, whatever. Inlet transverse is more. So next is oblique, next is AP, 13, 12, 11. Cavity 12, 12. There is nothing called oblique diameter in the cavity, only AP and transverse. Again in outlet, AP is more. In outlet, here AP is more when compared to this transverse. So that is, if AP is more, that is again 13, 12, 11, or you can tell 11, 12, 13. So like that. So in AP, pelvic inlet, we learnt about the AP diameter. Then comes oblique. Oblique is from one sacroiliac joint to that of opposite iliopectineal eminence. So if it is right oblique diameter, that is from right sacroiliac joint to that of the left iliopectineal eminence. If it is left oblique diameter, that is from left sacroiliac joint to that of right iliac eminence. Okay. Then they will ask about boundaries of pelvic brim. Remember, it has pubic symphysis, then comes the crest, then is the tubercle, then upper border of symphysis upper border of pubic bone, that contains this pectineal line. Here comes the iliopectineal eminence. Iliopectineal eminence continues as iliopectineal line. Together all this consider as arcuate line. Upper border of pubic symphysis, iliopectineal eminence, iliopectineal line. Then comes the sacroiliac joint, then comes the ala of the sacrum, and comes the sacral promontory. Together, whole this called as linea terminalis. Okay, this is the boundary of pelvic brim. Again, I repeat, pubic symphysis, crest, tubercle, upper border of pubic symphysis, iliopectineal eminence, iliopectineal line, sacroiliac joint, ala of the sacrum, and then sacral promontory. Okay, how to remember crest is first or tubercle is first? Remember CT scan. crust is first, then comes C. Crust is first, then comes the T, that is tubercle. Okay, this is with respect to the inlet, epidiameter, oblique diameter and boundaries of pelvic brim. So yeah, transverse diameter is the maximum distance between the two iliac bone, that is the transverse diameter, and which is 13.5 centimeter. So when the head comes and engages in the biparietal diameter, that is in the transverse diameter. Okay, then coming to the cavity you have two diameters. One is plane of greatest pelvic dimension, another is plane of least pelvic dimension. See this protrusion, whatever is there, that is ischial spine. Okay, can you able to see ischial spine? Here one is ischial spine, another one ischial spine is here. This is plane of least pelvic dimension. The distance between the two iliac spine, two ischial spine. So don't tell it as interspinous diameter. Tell it as bispinous diameter. That normal distance is 10 centimeter. If you are able to palpate two ischial spine at a time, that means that pelvis is contracted. Okay, that is plane of least pelvic dimension. Plane of greatest pelvic dimension is again the maximum distance between the two iliopectineal eminence. Okay, see in mid cavity, if they ask boundary, that is one the pubic symphysis, then comes the ischial spine, and behind it is S2, S3. That is sacral bone S2 and S3. Okay, then coming to the outlet is bounded by pubic symphysis anteriorly and the coccyx posteriorly and ischial tuberosities laterally. So if you write a line, imaginary line joining between the two ischial tuberosity, so the outlet is divided into two triangles. One is urogenital triangle, another is anal triangle. Okay, this is anatomical outlet. Okay, so the pelvis has it has a birth canal direction is directed downwards, backwards, and then again directed downwards and then forwards. Okay, this is the birth canal or axis of the birth canal. Okay, so then they will ask, after this they will ask, how do you assess the pelvis? So how do I assess the pelvis is, first I will take the consent from the patient. I will make sure privacy is there. I will well cover the patient. I will inform the patient what I am going to do. I will explain the procedure to the patient. And then I will ask her to empty her bladder. After getting the consent, I will make her to lay in dorsal position and with my hands, which is sterilized and warmed. Now I will put a sterile glove, and with the help of my two fingers, I will assess the pelvis. First, I will go with the help of lubricants. After putting the lubricant, I will go inside the per vaginum and I will try to touch the sacral promontory. Usually, sacral promontory is not palpable. If it is palpable, then I will come out. See, this is the thumb which is outside. So, I will come out. What is the distance I will measure? So, this is the distance from here to here. What is the distance I will measure? That is diagonal conjugate. Minus 1.5 centimeter, we will get obstetric conjugate. Okay. Then after this, after touching the sacral promontory, I will just come downwards. I will feel for the sacral curvature, whether it is concave or convex. Usually it will be concave. Then after coming this, I will come down and I will palpate for the coccyx, whether the coccyx is easily mobile, sacrococcygeal joint is mobile or not. Okay, so that I will see in the sacrum. Then from the sacral promontory, I will go sidewise. I will palpate the ala of sacrum. Then I will come for some foramina. This foramina is called greater sciatic notch, right? Sacrosciatic foramen. This sacrosciatic foramen I palpate and I will make sure it admits two fingers. Okay, then I will come downwards and I will palpate ischial spine. When I palpate the ischial spine, at the same time I will stretch my hand to palpate another side ischial spine. If I am able to palpate both the spines together, that means bispinous diameter is reduced. So this is a contracted pelvis. Then from the ischial spine, I will come downwards. I will come near the subpubic angle. If the subpubic angle is obtuse, it is a gynecoid pelvis. If it is acute, then it is android pelvis. If the subpubic angle is acute, there will be more waist space of Morris, that is behind the pubic symphysis. So that will hamper the delivery or it will prolong the delivery of the baby. Then I will make sure the outlet admits 4 knuckles. When I am coming from the sideways, I will even make sure whether the sideways are parallel or sideways are convergent. So I repeat, when I am doing PV, I will check for the palpable sacral promontory. If it is palpable, I will measure the distance. If sacral promontory not palpable, that means it is adequate pelvis. From sacral promontory, I will go downwards. I will check for whether the sacrum is concave or convex, and I will check the mobility of sacrococcygeal joint and coccyx. Then when I am coming sideways, I will check whether the sideways are parallel or convergent. And again, while going sideways, I make sure the sacroiliac notch admits 2 fingers, and then I palpate the ischial spine. Make sure the 2 ischial spines are not palpable at a time. Then I will come downwards and see for subpubic angle and the outlet which admits 4 knuckle. This is how I will assess the pelvis. Thank you. This is Dr. TSR. If you like, share, subscribe. Thank you.